So welcome. In this session, we'll be discussing mainly on vasovasculitis. This is the second part. I did the first part where we discussed about polyarteritis nodosa. In this part, we'll be discussing Kawasaki's disease. Those of you who are a fan of Wakadinali, they must have heard they mentioned Kawasaki in their recent song Sikutambui. Welcome all, my name is Wallace Munyeri and I'm the daktari. Now, Kawasaki's disease. Now, what is it? It is an acute febrile, so there must be a fever, self-limited illness of infancy, so infancy and childhood associated with an arteritis of mainly large to medium-sized vessels. Now, because it is associated with infancy, it was earlier named infantile polyarteritis because 80% of the patients are younger than 4 years. So it is infantile polyarteritis. Now, its clinical significance usually stem from the involvement of the coronary arteries. Okay, so it has a tropism for coronary arteries, and that can lead to coronary artery occlusion and or aneurysms or even rupture, and this will cause myocardial infarction. So if you are asked which of the vasculitis is mainly implicated in the causation of infantile myocardial infarctions, please remember Kawasaki's disease. It was Japan, originally described in Japan. I think we have a place known as Kawasaki in Japan because they have even Kawasaki motorcycles and even cars. So, but it is now recognized in the States and even elsewhere. So, even if it is called Kawasaki, that does not mean the effects on the Japanese. Now, in genetically, so genes play a role. So in genetically susceptible individuals, a variety of infectious agents, mainly viral infections, are postulated to trigger the disease. Okay, now, and this may result from a delayed type hypersensitivity response directed against cross-reactive or newly uncovered vascular antigens and subsequent cytokine production and polyclonal B cell activation, which result in autoantibodies to the endothelial cells and smooth muscle cells that precipitate the vasculitis. So in this type of vasculitis, there will be anti-endothelial antibodies, autoantibodies, okay? And also antibodies directed against the vascular smooth muscles, okay? Now, its morphology, it resembles polyarteritis nodosa. So there'll be that necrotizing inflammation, and that dense transmural inflammatory infiltrate, but the fibrinoid necrosis is less prominent, okay, than that seen in polyarteritis nodosa. Now, the vasculitis typically subsides spontaneously or in response to treatment, okay? I'll be telling you what you use to treat. But that vasculitis may lead to vessel wall weakening, and that can predispose to aneurysm formation, okay? As with other forms of arteritis, or is the plural form of arteritis, healing may be accompanied by the development of obstructive intimal thickening. Remember the stereotypical response of we said that intimal thickening is the stereotypical response to endothelial injury. Now, pathologic changes outside the cardiovascular system are very significant, okay? So, here we are, you can see, yes, there is fibrinoid necrosis, but it is not as prominent as that seen in polyarteritis nodosa. You can also see the inflammatory infiltrate, and it will be transmural, okay? So, that is what we observe, okay? So, Kawasaki's disease criteria, or now the clinical features. Now, if you want to diagnose Kawasaki disease, there must, let me say that there must be presence of a fever. I told you it is an acute febrile, okay? So fever, this is the most important constitutional symptom for greater than 5 days plus any of the four of the following. So fever, so remember fever, there must be a fever, and so fever plus other four of the following. After fever, you please remember this mnemonic, cream, okay, cream. Now, C, conjunctivitis. Now, a non-exudative or a non-purulent conjunctivitis, that is, then a rash, which is a polymorphous non-vesicular rash, then edema or erythema of hands or feet, then adenopathy, cervical adenopathy, which is often unilateral or and non-suppurative. So it will not be like that of a scrofula. Remember the scrofula caused by Mycobacterium scrofuli. So it is non-suppurative. Hence, due to this adenopathy, its other name is mucocutaneous lymph node syndrome. So the other name of Kawasaki's disease is mucocutaneous lymph node syndrome. Also, there is mucosal involvement. Okay, so there is erythema or fissures or crusting. Even at times, the tongue is involved, where the tongue will look like a strawberry. See how a strawberry looks like? So it is known as a strawberry tongue. Okay, so let me show you that. Now, you can see this is a conjunctivitis, but it is non-suppurative or non-exudative. Then you can see this child is very sad. Sorry to him or her. You can see the lips are crusted, okay? So mucosal involvement. Then you can see the tongue, strawberry tongue. And you can also see these lips how crusted and fissured they are. Then you can see here that a cervical adenopathy, unilateral. So due to this, it is also known as mucocutaneous lymph node syndrome. Sorry to this child. Can also see how the lips are crusted. Okay, then you can see the feet here, how erythematous it is, and also the hands here. Okay, so these are some of the signs and symptoms of Kawasaki disease. So please remember, let me go back. Cream, okay, conjunctivitis, rash, edema or erythema of the hands or feet, adenopathy, mucosal involvement, the crusting of the fissures, especially of the mucosa of the lips, okay, as I've shown you here, okay. Now, I think, how do you treat? Now, IV, intravenous immunoglobulin infusions, and this will suppress inflammation. But still, how do they do that? Through unclear mechanisms. They're still not clear how they do so. Now, aspirin, you'll ask yourself, you'll ask me, but you said aspirin will cause rice syndrome in children, because I told you this is a disease mainly affecting the children. Yes, there is always the risk of aspirin causing rice syndrome, but here you will weigh the risks. It's either the child gets rice syndrome or a myocardial infarction. So you weigh the risks, and I know you will concur with me that myocardial infarction is more fatal. So you use it, but you monitor it, okay? So this will decrease the incidence of symptomatic coronary artery disease. The coronary artery disease now are the ones which will now lead to myocardial infarction. I think that is that. It was that simple, okay? So thank you for your attention, guys. And next, we are done with, I know still there is Buerger's disease or the thromboangiitis obliterans, which is still under medium vessel vasculitis. We look at that at another time. So follow for more of med content, and thank you for your attention, and have a good day.